Let's talk about circulating tumor DNA and the results of the ZEST trial that was presented at the San Antonio Breast Cancer Symposium. Before I tell you about the results of the trial, let's talk a little bit about circulating tumor DNA. ctDNA essentially is DNA that cancer cells shed into the bloodstream as they die, and it is a sign of molecular residual disease, or MRD. So the idea is that there's cancer cells floating around and they're shedding DNA into the bloodstream. And naturally, there's a lot of interest in using this technology to identify perhaps people at risk for a recurrence or people who may recur in the future, but we don't always know what to do with the results. So if someone has a circulating tumor DNA test that's positive and then the next step would be to get a scan to see if there is radiologic evidence of disease. If there is, we go on to treat that patient. But we don't actually know at this point is just, finding that ctDNA, getting that imaging and starting treatment earlier than we would have had that person develop symptoms and then prompted that imaging. Does starting that treatment earlier prolong survival or improve outcomes? So these are what some of the studies are attempting to look at. Number two, what happens if you have a positive circulating tumor DNA but negative imaging? And we don't know what to do in that situation. Although there are some false positives and some false negatives, there is a very high likelihood that patient will develop a recurrence in the future. But as of right now, we don't know what to intervene with. Can we intervene with a medication that's going to make that positive ctDNA test turn negative? And can we actually prevent a recurrence? So these are where a lot of the questions lie. And this is where a lot of the ongoing clinical trials are attempting to answer. So let's talk about the ZEST trial, which was one of those studies. So the ZEST trial was a really highly anticipated study. It looked at patients who had stage 1 to 3 triple negative breast cancer or BRCA mutated hormone receptor positive breast cancer. And they screened patients with circulating tumor DNA. And for patients that had a positive ctDNA, negative imaging, they were going to be randomized either to receive placebo or to receive niraparib, which is a PARP inhibitor. And the goal was, can giving niraparib prevent a recurrence? Now, they had about 1,900 patients who enrolled onto the study, and only about 8% of them had a positive circulating tumor DNA test. So this is actually good. Most people did not have a positive circulating tumor DNA test, but it left us with a very, very low number. Turned out that half of those patients with a circulating tumor DNA test, when they were scanned, had radiologic evidence of progression. So they were no longer eligible, and a number of patients were ineligible for other reasons. And so that only left the study with 40 patients that could be randomized to receive placebo or niraparib. Unfortunately, this was an insufficient number to do any sort of meaningful analyses. What they did find was that the recurrence-free interval was longer for patients who received niraparib. It was 11.4 months in the niraparib arm and 5.4 months in the placebo arm. But again, those numbers, because of how small they are, it's not enough to draw any sort of conclusions, but numerically it was better with the niraparib. Unfortunately, this study was terminated early because of the low detection of ctDNA, and so it does not answer this question about, can we give patients in this population niraparib? We just don't have that information. There are a number of studies ongoing that are attempting to answer similar questions with different interventions, both in triple negative and hormone receptor positive and HER2 positive, but we're not there yet. I would love to know your thoughts, and whether you've done ctDNA. If you haven't done it, what was your decision process like? And I think that will help others who are thinking about this as well. Leave it in the comments.